Okay, let's unpack this. We're diving into the ear, an organ that is fundamentally dual in its function. It's not just the microphone of the body, handling sound. It's also the gyroscope, managing our balance and equilibrium. We're exploring the architecture of this pretty complex system and, maybe more importantly, the common ways it can, well, fail us.
Yeah, what's fascinating right off the bat is just how common these disorders are across the whole lifespan. You've got acute otitis media, AOM, which is like the top reason kids get antimicrobial prescriptions. Then at the other end, you see hearing loss and chronic vertigo becoming major causes of disability, especially as people get older. So understand the pathophysiology, the how and why these things happen. That's really the shortcut to, effective treatment.
Right. Our goal today is to give you that clinical and mechanical understanding. We're going to sort of follow the path of a sound wave, starting from the outside and moving deep into the inner ear. We'll look at conductive disorders first and then get into the sensorineural stuff and the vestibular failures.
Okay, so to start, sound hits the external ear, that's the auricle, the part you see, and the acoustic meatus, the ear canal, and right away is protected by cerumen, or earwax. Now, cerumen's good, it's protective, even antimicrobial, but when it gets impacted, it forms a physical block. It's reversible, thankfully, but it causes conductive hearing loss, fullness, and often that ringing sound, tinnitus.
And here's a really interesting little neurological quirk for such a tiny structure. The external ear canal, it's actually wired by the vagus nerve, specifically its auricular branch. So if that wax is really jammed in there, or even during removal, stimulating that nerve can trigger, well, systemic stuff,
Right.
like an intense coughing fit, or even, and this is a bit worrying, a slowing of the heart rate, cardiac deceleration. So that little canal definitely has connections beyond just the ear.
Oh, absolutely. It connects much further than you'd think.
Yeah.
Moving just a bit deeper, you get inflammation of the external ear, otitis externa. Most people know it as swimmer's ear. This is often bacterial, things like Pseudomonas or Proteus, which just love excess moisture in the canal, or sometimes fungal, like Aspergillus. And you see those local signs pain, especially if you wiggle the ear, and sometimes discharge, what we call otorrhea.
Okay, so past the eardrum, we're into the middle ear. This is where those three tiny ossicles live, the malleus, ingurtus, and stapes. They're the mechanical link, transmitting vibrations. And this is also the territory of the eustachian tube, the ET. Its job is super important. Pressure equalization, think flying or diving, plus protection and drainage for the middle ear. But why does this tube seem almost designed to cause problems in kids?
Yeah, it's really a structural development thing. In children, the eustachian tube is shorter, it's wider, and it sits much more horizontally compared to in adults. And that single anatomical difference makes it way easier for air, fluids, even bacteria to reflux from the back of the nose, the nasopharynx, right up into the middle ear space. That's exactly why pediatricians advise against bottle feeding babies while they're lying flat. It literally helps gravity push stuff up that tube.
Wow. So that structural vulnerability links directly to things like barotrauma. That's the ear pain or damage from really rapid pressure changes, like on a plane coming down fast when the tube just can't keep up. The pressure difference can actually be bad enough to cause bruising or even tear the eardrum, the tympanic membrane.
And that naturally leads us to the two main types of middle ear inflammation, otitis media or OM. And distinguishing between them is crucial, especially with all the pressure about antibiotic overuse. So acute otitis media, AOM, that's the infection, it comes on suddenly. You get acute ear pain otalgia, often a fever, usually over 39 Celsius, and fluid effusion in the middle ear. Clinically, when you look, the eardrum is red, erythematous, and it doesn't move well.
Right. But the big clinical challenge, the thing that probably drives a lot of unnecessary antibiotic use, is telling that apart from otitis media with effusion, OME, with OME, you still have fluid there. But those acute signs of infection, the high fever, the really bad pain they're missing, you might look in the ear and see sort of an amber-colored fluid level, maybe even a bubble behind the eardrum. And this difference is critical because OME often clears up on its own. It generally does not need antibiotics. But trying to tell the difference in a squirming toddler under an otoscope, well, that can be incredibly tough.
Exactly. That clinical differentiation is paramount. Now, shifting to something more mechanical and chronic, let's touch on otosclerosis. This is a hereditary bone disease. Basically, new spongy bone starts forming around the stapes, one of the ossicles, and the oval window where it connects to the inner ear. And this new bone essentially freezes the stapes in place. It gets fixed, immobile.
Okay, so if the stapes can't vibrate, the sound waves can't get transmitted properly into the inner ear fluid. That causes a progressive conductive hearing loss. Makes sense. But explain the weird paradox here. Why do patients often say their own voice sounds really loud and that they actually hear better in noisy places? That's the masking effect, right?
That is the masking effect, yeah? And it's a neat bit of physics because the conductive loss is blocking external sounds from getting in efficiently. The person's own voice, which reaches their inner ear mainly through bone conduction in their skull, sounds amplified, almost booming to them. And in a noisy environment, everyone else has to talk louder to be heard over the background noise. Since louder sounds might sometimes bypass that fixed state through other vibration routes, the person with otosclerosis actually benefits from that increased volume, whereas someone with sensorineural loss would just find the noise more garbled and distorted. So if conductive loss is often fixable, sensorineural hearing loss, SNHL, is usually permanent damage. This means trouble in the inner ear itself, the cochlea, those delicate hair cells, or along the auditory nerve pathway to the brain. We categorize hearing loss using decibel thresholds, dB mild, moderate, severe, and profound loss is typically defined as 91 dBt or greater.
And SNHLs where the risks get, well, pretty serious. Beyond genetic factors or physical trauma, a huge risk comes from just exposure. Sustained noise over about 100 to 120 dB, think loud concerts without protection. Heavy machinery, day after day, it causes permanent mechanical destruction of the hair cells in the organ of Corti. And once those specialized cells are gone, they don't grow back.
And we absolutely have to talk about the chemical assault on the inner ear. Ototoxic drugs. There are several classes of medications that can unfortunately destroy these hair cells. Key culprits include certain antibiotics, specifically aminoglycosides, also some potent loop diuretics like furosemide, and even high doses of salicylates like aspirin. And the risk gets much higher if the patient also has kidney problems because the drug levels can build up in the blood and therefore in the inner ear fluids, reaching toxic concentrations.
Probably the most common form of SNHL we see is presbycusis. That's age-related hearing loss. It's typically gradual, affects both ears, and it tends to hit the high-frequency sounds first. So the main complaint often isn't, I can't hear volume, it's I can't understand speech clearly. They miss consonants, so words like mash and math or fish and wish sound the same. That loss of clarity is what really impacts communication.
Yeah, and this often goes hand in hand with tinnitus, that perception of sound ringing, buzzing, hissing, clicking that isn't actually coming from the outside world. Now, there's rare objective tinnitus, sometimes caused by blood vessel issues near the ear that someone else might even hear. But most tinnitus is subjective. It's linked strongly to noise exposure damage, aging, sometimes high blood pressure. One leading theory is that tinnitus is basically the brain trying to compensate for lost input. When damaged hair cells stop sending signals for certain frequencies, the central auditory system might sort of turn up the gain internally, creating this phantom noise to fill the silence.
Which makes the treatment approach really interesting because it's not always just medical. If the brain is generating the noise, treatments often involve things like masking devices introducing a gentle competing sound, or even psychological approaches like cognitive behavioral therapy to help change the person's emotional reaction and attention to the tinnitus sound.
And then just quickly, at the bedside, to help tell conductive from sensorineural loss, use simple tuning fork tests. The RIN test compares hearing through air conduction versus bone conduction. Normally, air is louder, but with conductive loss, like that otosclerosis, bone conduction actually sounds louder than air conduction. That's a key sign. And the Weber test helps see if the sound seems louder in one ear or the other, which helps pinpoint the type and location of the loss.
And for individuals with profound SNHL, where the cochlea is damaged but the auditory nerve itself is still working, cochlear implants have been just revolutionary. They essentially bypass the broken part, they pick up sound, convert it into electrical signals, and send those signals directly to stimulate the auditory nerve fibers, creating a perception of sound in the brain.
Okay, so we've seen how structure and sensory cells failing can wreck hearing. Now let's pivot to the inner ear's other incredible job. Vestibular function. Balance. Deep inside that bony labyrinth contains the semicircular canals. They detect rotational movement, like turning your head, and also the otolithic organs, the utricle and saccule, which sense linear movement, like accelerating in a car, and also static head position, gravity.
Right. And when this complex system gets disrupted, the most striking symptom is usually vertigo. And it's crucial to distinguish this. Vertigo is an illusion of motion, a definite spinning or whirling sensation. It's not just feeling lightheaded or like you might faint, which we call presyncope. Vertigo can be objective, feeling like the room is spinning around you, or subjective, feeling like you yourself are spinning. And that messed up input from the inner ear also shows up in eye movements, right? That involuntary, often jerky, rhythmic eye movement is called nystagmus. It happens because the vestibulo-ocular reflex, the VOR, which normally keeps your vision stable when you move your head, is getting faulty signals from the balance system.
Exactly. And broadly, we categorize vertigo based on where the problem lies. Peripheral vertigo starts in the inner ear structures, or the vestibular nerve itself, CNA8. It tends to be quite severe, comes in distinct attacks or episodes, and is usually brief. This is the most common type. Central vertigo, on the other hand, stems from problems in the central nervous system, the brainstem or cerebellum. This is often milder, but more constant, persistent, and chronic.
Okay, let's start with one almost everyone's experienced. Motion sickness. You said this is actually normal, physiologic vertigo. It sure doesn't feel normal. Why does reading in a car make it so much worse?
Huh. Yeah, it feels awful. But it's your body working correctly based on conflicting information. When you're reading in a moving car, your eyes are fixed on the page. Your visual system is telling your brain, everything's still, the page isn't moving.
Right.
But your vestibular system in your inner ear is detecting all the acceleration, deceleration, bumps, and turns of the car. It's that sensory conflict, that mismatch between the still signals from your eyes and the motion signals from your inner ear that triggers the whole cascade, nausea, vomiting, malaise. To fix it, you have to resolve the conflict. Either stop reading or look out the window so your eyes confirm the motion your inner ear is feeling.
Makes sense. Now, what about the most common cause of pathologic vertigo? The stuff that sends people to the doctor. That's benign paroxysmal positional vertigo, or BPPV. You mentioned it's mechanical.
Absolutely. It's purely mechanical, and the analogy is pretty good here. The problem involves these tiny calcium carbonate crystals called otoconia, or sometimes otoliths. Think of them as inner ear rocks or little calcium chips. They're normally stuck in gel in the utricle part of the otolithic organs. In BPPV, some of these rocks become dislodged. They break free and end up floating into one of the semicircular canals where they shouldn't be. So when the person moves their head into certain positions, like rolling over in bed or tilting their head back, gravity pulls on these loose crystals. The crystals drag the fluid in the canal with them, sending a powerful, false signal of intense rotation to the brain. This causes a sudden, severe, but usually very brief episode of vertigo, typically lasting less than a minute.
That brief position-triggered nature is the key clue then. Diagnosis often involves the Dix-Hallpike maneuver, a specific head movement to try and provoke the vertigo and see the resulting nystagmus. And the treatment sounds almost too simple, but it's also mechanical. Camelic repositioning maneuvers, like the Epley maneuver, right? Specific head movements designed to use gravity to guide those loose otoconia back out of the canal and into a less sensitive part of the inner ear.
Exactly. It's essentially using physics to fix a physics problem.
Mhm.
Now, switching gears from loose particles to fluid problems, we have Meniere disease. This is thought to be caused by distension or swelling of the endolymphatic compartment of the inner ear. It's called endolymphatic hydrops. Imagine the delicate fluid-filled sacs and tubes in the inner ear becoming overfilled, like a water balloon stretched too tight, putting pressure on the hearing and balance sensors.
And Meniere disease presents with that really classic severe triad of symptoms, doesn't it? Fluctuating hearing loss, usually low-frequency sensorineural loss initially, violent, spinning, rotary vertigo attacks that can last hours, and tinnitus or a sense of fullness in the affected ear. The attacks sound absolutely debilitating, often coming with severe autonomic symptoms too: pallor, sweating, intense nausea, and vomiting.
They are truly miserable for patients. Treatment focuses on trying to manage that presumed fluid imbalance. Often that means diuretics to reduce overall body fluid and, importantly, a strict low-sodium diet, as sodium influences fluid retention. And clinically, to assess static balance function, we might use something like the Romberg test. You have the person stand with feet together, first with eyes open, then eyes closed. Removing the visual input forces them to rely solely on their inner ear and proprioception, sense of body position, to stay upright. If they sway or fall with eyes closed, it points towards a vestibular or proprioceptive issue. Hashtag outro.
Wow. We've really covered a huge range of ways things can go wrong, from just a simple bit of wax blocking sound all the way to microscopic crystals or fluid imbalances, completely throwing off your sense of reality. I think the big takeaway has to be that distinction between the often fixable conductive problems like OME, earwax, otosclerosis needing surgery maybe, versus those typically permanent sensorineural issues, often from noise damage or those ototoxic drugs we need to be so careful with.
Absolutely. And for vertigo, remembering that core difference, the particle problem, that brief positional vertigo of BPPV treated with maneuvers, versus the fluid pressure problem, the chronic severe fluctuating attacks of Meniere disease
Yeah.
managed with diet medication. And if we connect this to the bigger picture, well, the ear is incredibly delicate and vulnerable, yes. But the symptoms it produces, when you really listen to the patient and examine them carefully, are often highly specific. They give us powerful clues for diagnosis.
Definitely. And finally, maybe a provocative thought to leave you with, just thinking about how deep this system really goes. We tend to think of the ear as the endpoint for sound, but the central auditory pathways in the brain are what actually give sound meaning. Consider damage to the Wernicke area, usually in the dominant left brain hemisphere. It doesn't make you deaf. You can still hear the physical sound, the vibration, perfectly well, but it causes auditory receptive aphasia. You hear the words, but your brain literally cannot decipher their meaning. It's like listening to a foreign language you don't know. It just highlights that true hearing, true understanding, is this incredibly complex process of integration deep within the CNS, far beyond just detecting a sound wave.
That's a powerful point. A reminder that the journey of sound and our sense of place in the world truly ends not just in the ear, but deep within our cognitive wiring. Thank you all for joining us for this deep dive into the, well, fascinating and sometimes frustrating world of hearing and vestibular function.
We really hope this brought some clarity to a complex topic. Thanks for listening, and we'll catch you on the next deep dive.